Well, good afternoon, everyone, and welcome to the weekly seminar series at the Dahdaleh Institute for Global Health Research. My name is Professor Mary Viktorovich, and I'm the Acting Director of the Dahdaleh Institute. Today, I'm delighted to host Dr. Eric Asempah, who will lead today's seminar titled HPV Vaccine Access and Cervical Cancer Policymaking Process in Ghana, Rwanda, and Canada. As is our usual practice, I'd like to begin by acknowledging the Indigenous land that we're on. And as this is a hybrid event and some guests are on different territories, please take the time to give thanks and respect to the land on which you're currently living and working. And as we're here at York University, we're mindful that we're situated on the traditional territorial area known as Toronto, and we acknowledge the current treaty holders, the Mississaugas of the Credit First Nation. We acknowledge this as the traditional territory of many Indigenous nations, including the Anishinaabe Nation, the Haudenosaunee Confederacy, the Huron-Wendat, and the Métis. This territory is subject of the Dish with One Spoon Walking Belt Covenant, an agreement to peaceably share and care for the Great Lakes region. So let's begin with a brief introduction to our speaker. Eric Asempah is a graduate scholar here at the Dahdaleh Institute, and he recently defended his PhD dissertation. He is a health policy researcher and pharmaceutical professional with over 14 years of industry experience. Eric's research interests focus on innovative policy models and frameworks that support the public policy-making process and health equity. In today's seminar, Eric will address the pressing global health issue of limited prophylactic vaccine that can prevent HPV-related cervical cancers in low to middle income countries, particularly in Sub-Saharan Africa. Cervical cancer claims the lives of 600,000 individuals worldwide, with Sub-Saharan Africa being a significant burden of the cases reported. Eric will analyze the similarities and differences in policy making and the context the HPV vaccine and cervical cancer programs were planned in, developed and implemented. His research looks at policies and programs in Canada, Rwanda, and Ghana using a comparative lens. So over to you, Eric.
Thank you very much, Mary. Thanks everyone also online and everybody here. So as indicated, my research focuses on HPV vaccine access and then cervical cancer policymaking process. So I look at the cases in policymaking cases in Ghana, Rwanda, and then Canada. I would wish to declare that I do work for a pharmaceutical company and there is no conflict of interest whatsoever. And so my key motivation for this particular project spanned from the fact that I want to see prophylactic vaccines made available to the underserved regions, women in underserved regions who are impacted with cervical cancer, who are exposed to HPV vaccines, high risk HPV vaccines, high HPV, sorry. So currently, cervical cancer tends to affect nearly 600,000 women in terms of diagnosis, and then about half of that number goes into mortality. That being said, we do have vaccines that are available. About 99% of the cervical cancer cases are being reported to be caused by high-risk HPV. The human papillomavirus, we do have about 17 oncogenic strains of that, and out of these oncogenic strains, the strains 16 and 18 have been identified to be a greater cause of cervical cancer, about 70% of all of this. And while that is the case, there are vaccines that are available. We do have Merck producing the Dahdaleh, and then GSK making Cervarix available as well. And recently, we had the Chinese company Xiamen producing Zicolin, and the anticipation is that this new vaccines is going to be the game changer in making the vaccine available to underserved regions. The current situation is that in the underserved regions, we do have about just 25% of the countries in these regions having some form of program that have the HPV vaccine as their as part of their national immunization program. And in high-income countries where the prevalence is not so high, about 80% of these countries will have a national program. And the reason for this has been that there isn't any much initiation in terms of policy agenda, as well as early screening to detect cervical cancer lesions and stuff like that. So these are some of the issues that are proponing or pushing towards a cervical cancer case increase in these regions. The rationale for comparing Canada, Rwanda, and then Ghana are based on the grounds that in Rwanda and Ghana, they do have the option of getting assistance from Gavi to be able to initiate a program. And then when it comes to Canada as well, the provinces and territories are able to get assistance from the government. And all of these three countries do have some national health insurance schemes, which supports the fact that individuals who have access to the national access to insurance will be able to get access to the vaccine if the vaccines are available in the first place. And then also all these three countries subscribe to the WHO's ideal of universal coverage. So the comparing these countries are based on these grounds. So currently we have the WHO having an agenda to eliminate cervical cancer by 2030. And then the approach is that by 2030, 90% of all women, all girls will be vaccinated by the age of 15. They will be vaccinated with one of the available vaccines that is available, that is on market now. And then 70% of all women between the ages of 15 and 45, will be screened for precancerous lesions. And then 90% of women who have been identified with the disease, will be treated. And whilst that is the case, the current situation in Africa is that we have very few number of the countries in the Sub-Saharan region having some form of program to vaccinate girls. And we did have Nigeria coming on board just last month. So we have 13 in all, and then Rwanda was the first to have initiated this program countrywide. So between that was in 2011. So when we look at 2011 till now, we only have 13. That is, we have 33 countries left. Meaning, if we want to go by this same approach, it's going to take another 30 years for the entire Sub-Saharan region to be covered. That will mean that the WHO's agenda is not something that we can actually meet, and we have to move very fast towards getting the other countries that do not have the program, on track in doing that. The approach in performing that was used in conducting this study was qualitative and then quantitative data collection. So I did the qualitative data collection, and quantitative was an approach for Ghana and then Rwanda, where key informants were interviewed, and then also public opinions were also sought to understand the situation. And then in the case of Canada, scoping review was conducted, and also the literature was reviewed as well. The scoping review was conducted specifically for Ontario to understand the policy making process for Ontario because of the size of Ontario. Also, it being the case in the policy making case in Ontario have been more unique as opposed to the other provinces. The policy making in Ontario, as far as the HPV vaccine program was concerned, was a little bit fast, and they use a sense making. That is, they use information that were provided by the vaccine manufacturer. So policymakers had to move between facts and then contradiction, whether they had to go by it. So there wasn't enough time for them to look into certain evidences whether the vaccine itself was efficacious at the time, because the vaccine had just been approved by the FDA, and it just took a year for the vaccine to be sold, to get market authorization in Canada. So policymakers did not have sufficient time to really understand the effectiveness of the vaccine or its safety on the market. However, they proceeded to, have the program. So that creates a lot of room for, variability. You cannot tell whether the program, the vaccine that is being given to girls was safe or not. So by that approach, I kind of moved into this model whereby we need to test whether the policy to kind of strengthen the policy making. So I have this test whereby we have to assess the vaccine, or policymakers have to first of all look at the vaccine that is justified, the policy that they are making, the choice that they want to go with. Is it justified? And then also, is it one that is distributive? If they want to go by that approach, is it going to help the entire, is going to help only girls, or is going to help girls and then boys? And then also you have to look at the practicality of the vaccine, and also whether the vaccine itself really speak into the intervention that it says it intends to do. We also have to look whether the policy is cost effective or not. So I developed this kind of wrote down this algorithm to support this policy making process with the support of a program, a software developer, to see if you can develop something to help policymakers on that stream. So it kind of would function this way. Let's quickly run this test to see how it works. So this is how kind of it works. So in this case, me being supposing I'm a policymaker, I have this as an app or on my browser, sitting in a conference room or at home trying to support the policy making process. I need to establish that the policy making is justified or is redistributive, and then situational evidence must also support the practicality and interventional, interventionality of the policy. So based on your selection, the system will be able to predict what your outcome is, and then you must also provide some form of commentary. And then based on all of this, we are trying to put in an AI where the AI will be able to predict the comments that have been entered. It actually supports the entire entry that the stakeholder has made. So at the end of the day, at the back end, it will actually show a trend as to what the policymakers are indicating supports their commentary. And if they also have some evidences and they attach the documents for the reasons why they actually chose those particular, made those particular choices, the AI will actually assess all those documents as well, and also make the prediction. And at the end of the day, it's able to provide, based on everybody's assessment, whether the policy that they are making is actually a viable one that can actually stand the test of time over the long period. And in the case of Canada, we did this on a trial from, let's suppose me as a policymaker. All the choices were picked as yes, because the decision to vaccinate girls was practical, and it was also justified and interventional. And then at the end of the day, it's kind of shown that the policy was effective, from one end. However, it's most likely that this might change if another individual is to assess it. So this is still in the process of being strengthened as a policy tool. So the Rwandan case, thankfully, we were able to successfully have it published. So if you are interested to, look into how that policymaking process happened, it's a very interesting read. I will recommend it for everybody here. The Rwandan policymaking process occurred with the president's wife having a meeting with the MEX executives. And then based on that meeting, MEC decided to provide the country, donate 2 million doses of vaccine to the country for them to initiate the program. 1 year after that meeting, MEC officials were in the country to support the country to build up a policy structure for them to proceed with the program. And prior to that, the country also had set up, working groups to support the entire process. So, and also Rwanda does have its own traditional policy-making models that also supported the entire policy-making process for the HPV vaccination. So these factors actually supported Rwanda being able to move very quickly and smoothly into its nationwide HPV vaccination program. But it's also instructive to point out that it did not really find it easy because it did have some adversarial actors who were against that formation, indicating that, the policy was not in favor of the country, considering that it did have some other competing concerns that it has to focus on. And also the fact that the minister at the time was on the Gavi board who were supporting the program. So those became grounds on which these adversaries were speaking against the program. However, the minister was able to successfully maneuver through this, and there weren't any form of attack to prevent the program to happening. So the program successfully happened, unlike other countries where there were a lot of drawbacks because of similar adversarial attacks. In the case of Ghana, the public outlook, or before, there was HPV awareness in itself was very low, but from the study that was performed, the awareness is increasing, especially through schools and self-reading, and internet is also enhancing people's awareness of HPV, in general. And then people's thought on the government supporting the HPV vaccination program is a little bit low, and then the government, whether government will be able to allocate resource and all of that is also not too high. So there's a little bit of concern, and that means that government will need to put in a lot of prioritize this. And then when it comes to, with all this, what's happening is there's also a good window of opportunity for the country, in that majority of the individuals who participated in the survey indicated debuting sex much later in their life, after 17 years, meaning there's a lot of room for the government to succeed if you decide to pursue an HPV vaccination program. And one of the key informants during the interview indicated that in the case of Ghana, it's not as if they have any form of issue with developing policy to tackle HPV vaccination among girls. The issue much more is about implementing the policies that they have. And then also the fact most of the time it's been blamed on the fact that they don't have money for it, and that is what has always been the excuse. In comparing these three countries, the teams that were the public health and governance systems of these countries, and then the number of women in politics as well, and then the priority settings, imperatives, and resource allocations, and then the way policymaking process really happens in these countries. So for the governance and political framework, looking at all of the themes that we looked at, it's been realized that when it comes to Rwanda, there are a lot of similarities, and then these similarities, Rwanda and Ghana do have the centralized approach, whereas Canada is fragmented mainly because of the provinces and then the territories being autonomous in the way they do their governance, And then when it comes to competing priorities for other infectious disease in Rwanda and then Ghana, it is very high. So whilst it's very low in Canada, so in places like a place like Ghana, because they do have other issues, other health issues to really tackle, they might prefer to maybe proceed with maybe perhaps HIV rather than cervical cancer, or breast cancer rather than cervical cancer. So those competing health issues become an area of of concern. The same with Rwanda. However, it takes a lot of effort and impetus for them to target this particular concerning area of policy, like I said, cervical cancer. And then when it comes to women representation, it is very low in Ghana. So it means that issues that affect women may not necessarily have a very high priority because there wouldn't be too much representation to, front it up in that sense. This rather actually also shows the presence of actors who have the power to make some of the policies to happen. And in Canada, it's kind of in between. But however, when you take Rwanda, all the stakeholders that were looked at, that is the pharmaceutical company providing the resource, the non-profit organizations in the country, policy entrepreneurs and all of that, there is a higher interest, and then even though some of them may not have enough power, but the level of interest is very high. And because the level of interest is very high, it kind of opens the door for them to push for this agenda because everybody tends to be on board. And then when you look at Ghana, the interest is not so high in some of the cases. So all of these, situation tends to pull the entire, energy for the stakeholders to push for a singular front to have an HPV vaccination program or a kind of, program, a kind of program to support HPV awareness or cervical cancer, prevention or control in the country. When we compare all the three countries, some of the similarities happen to be, especially for the countries that have HPV vaccination program in Canada and then Rwanda, we realize that they do have a very strong, cohesive, multi-stakeholder engagement. In Ghana, it is very loose, and because of that looseness, there's not a strong front for them to, combat or speak on this particular case. And then also, whereas Gavi that supports, Rwanda, Ghana also has that opportunity, but it did actually exploit at some point where Gavi was in a country to have a demonstration program for 2013 and then 14. But the problem is that after the demonstration, there is no documentation whether it was successful or not. So we cannot tell whether the Gavi program went well or it did not. So that is one issue with that. And then also there is a very good number of girls the age of 14 and under in all of these regions. That means there's a lot of opportunity for for HPV vaccination, especially in Ghana, which doesn't have any such program. And then in general, when it comes to resource allocation, Ghana does consistently complain of inadequate resource allocation for health. In fact, that is the case. If you look at the health expenditure per capita, it is not that sufficient. So indeed, resource allocation in Ghana and also in Rwanda is not that very sufficient. However, it did not prevent Rwanda from pursuing the agenda to have an HPV vaccination program. What is happening is I do have this program and this framework to support the entire policymaking structure in not necessarily in Africa per se, but in general. So what happens is it points out where the lacks are. So we have where all the issues coming in, and then it shows where effort needs to be put. So once the issues go into the funnel, we look at where the resources need to be coming from. So once the resources are coming in, how do we really get the resource going through the pipes? And then if we have to do a pilot program, how do we manage that? So we're trying to have this in such a way that it becomes a planning, a policy planning resource, and that can be technologized more or less, and then have the policy choice, which was used in the Canada case, imputed. So once maybe a choice is selected, that choice will have a spot in there to test whether the choice that they want to really test is viable and is something that should be pushed through the pilot phase or not. And hopefully this will be something that will be able to support in the entire policymaking process. The implication for the study is showing that there is a window of opportunity, as indicated in the case of Ghana, that females are taking, most of the girls in Ghana debut sex much later in life. So there is opportunity for the government to pursue this now rather than waiting much longer. And then Canada and then Rwanda have proven that whether you have plenty resources or you do not have plenty resources, there's always opportunity to leverage for HPV vaccine program. And the approach to prioritize to having HPV as part of a national program, I think could be the COVAX type strategy. This is because when we take Canada, Canada was successful because it did have resource from the federal government that supported the other provinces and the territories to tap into and then, have their program. Prior to the government, the federal government making this resource available. For instance, Ontario was pulling out, wasn't really ready for the HPV vaccination for girls, but when the federal government came in, it actually opted to go in for it. And Rwanda as well, because it was able to get the donation from MEC, it was able to proceed with that. So in the case of having this approach, when there is a bigger pool where these countries that do not have the HPV vaccination program can actually go in and then tap into that resource, it becomes easy for them because that way they don't have to necessarily work very hard into allocating resource for that. So that the COVAX type strategy is one that I believe is going to help in regionalizing HPV vaccination program overall. And then the policy stability check as well is going to support policymakers to know whether the strategy or the choices that they are making to have to push forward a program like HPV vaccination is going to succeed or not succeed. And so these are some of the implications and then the contributions. And then also we did a scoping review, which is also showing that there isn't enough research in Africa, so there's a need for more research to be conducted on policy around the HPV vaccination and then cervical cancer in the region. So technically, that is all I have. This is just a synopsis of the entire work. It's not that highly dense, but I believe once questions begins to come in, it will support in dealing with some of the issues that actually occurred during the research overall. Thank you.
Great, thank you so much, Eric. I think your case studies individually are really interesting, especially the contrast between Rwanda and Ghana. So I'm wondering if anyone has any questions. I know I have a couple, but anyone would like to come forward or online? Okay, well, let me get the ball rolling.
Can I ask a question?
Yes, please go ahead.
Thank you so much. So having listened to the, sorry, I don't know what's going on. Thank you so much for the lecture. I'm from Africa, so I'm quite interested and also a female. And I just wanted to know the reason or what's unique about Rwanda to compare to Ghana and Canada and not other African countries, not any other African country. And why, what the uniqueness that of Rwanda that other African country can also compare or learn from?
Thank you. So the rationale for comparing Rwanda to Ghana and in fact Canada as well, and let me just do that for Rwanda in the first place, was because Rwanda is the first country to have had an HPV vaccination program. And not only that, Rwanda and then Ghana do have access to can access Gavi support for HPV vaccination. So that's set the grounds on set the pace, and then the economic structure between Rwanda and then Ghana is not any different. So those are some of the grounds on which, or the premise on which I did that as a comparison between Rwanda and then Ghana, that it set the pace for other countries technically to follow, because it's the first. So we need to know what Rwanda has done different that other countries can do. That is why I did that in a comparison. And then when it comes to Canada, it's also one of the OECD nations, that the first OECD nations to have had an HPV vaccination program. When the vaccine was became marketable in 2006, it was one of the first in 2007 to have this program. So it's kind of a good framework to also see what different approach that a high-income country took in trying to have this HPV vaccination program in its country. So comparing these different streams will help to know what could be learned from a high-income country and then from a low-income country. And then this learning can help to frame ahead what other countries can learn from.
But I think, if I may, Eric, she's asking what is unique in Rwanda that set it apart from the others? And so you did talk about it,
Okay.
like the champions and so on.
Okay, so what is unique about Rwanda is the leadership style. Okay, and then also when you look at the kind of I call them the problem entrepreneurs, like the president's wife, moving forward, taking the challenge to move with that agenda, making sure that she is able to get the support that it's needed. And then also the Rwanda does have some frameworks within the country that helps in them succeeding in programs like this. One being Imihingo and then Obedehe. So once the country set out a program, the individual or leadership or community leaders become responsible for the program. So these structures support the country from succeeding in any form of government programs. So these are some of the structures that kind of makes Rwanda unique in its program formation. And I believe, in my view, that the championship of this program by the president's wife was one of the core success factors in the program, in its success.
Right, and then they also one of the things Mrs. Kagame was able to do was also connect not only with the pharmaceutical company that provided the vaccines initially, but also with Gavi. That,
Okay.
Also when Merck's vaccines, were used up. So Gavi is an international organization that provides access to vaccines, and they cover some of the costs. And a country like Ghana could access support from Gavi as well, but they've simply chosen not to.
That's the case. And as I indicated too, Gavi in 2013 and 14 made the attempt to work with the Ministry of Health in Ghana to have a demonstration. So the way Gavi function is, they will first of all support you to have a demonstration to know whether you are able to get a good coverage for once you begin to administer the vaccines. So when they did that demonstration, there wasn't any report provided. So there's no, and we don't know what really cuts that whole relationship. So that is one of the things that I think we need to really figure out why that relationship was cut. And I think maybe perhaps they just decided not to continue with the program anymore. But Ghana still has that opportunity to have Gavi come on board to support the HPV vaccination program.
That's right. They could turn that around.
Yeah.
But I think they still have to contribute some funding to it, right?
Yeah.
Gavi will cover a lot of the vaccine costs, but not 100%. So the country itself has to contribute, but it's a much lower level, right?
Yeah, Gavi normally provide 80% of the entire program cost. They provide 80% of the vaccine cost and also the program cost, and then the country provides 20%. But the thing is that they don't have control on how you use that money. So, I mean, if they give you the resource and you mismanage it, they don't normally, they don't too much care about how you dispatch that.
Right, but it's an option, but, and so, at the end, Eric, you suggested a regional collaboration for vaccine access such as COVAX.
Yeah.
But does Gavi not already do that, or are you suggesting on top of what Gavi does?
So, Gavi really works with the individual countries, to execute, to have their HPV vaccination program. It doesn't work through the COVAX, structure, the way COVAX work for the COVID, system. So, because, and also not all the African countries are able to access Gavi, so if we do have a kind of COVAX system where the individual countries can assess it, where it will be like, okay, we are giving every country maybe 1 million doses of vaccine. So we also give you this amount of resource for your program development. So then the countries do not have to really think about going to look for money to buy the vaccines, or they don't have to really think about money to develop the program, because these resources are being provided already. Like in the case of COVID, if some of these countries were left on their own, there was no way they could have supported themselves. So that is, going by that approach seems to be a much more better approach, especially if you want to meet the WHO's 2030 strategy of eliminating cervical cancer. So the COVID strategy, in my view, is for as we stand right now, is more workable.
Interesting. And is there any proposal like that for HPV right now?
Currently, no. So individual countries are moving. So if you are able to access Gavi, you work with them. So Nigeria did that last month. They were able to get. They are planning to vaccinate 7.7 million of young girls between 12 and then 14 years. So everybody is trying to do this by themselves. And for countries that do have other competing health issues, they are not going to really pursue that particular path, because Gavi's resources these countries to deal with other health issues. So it could be HIV, it could be maybe any type of vaccine. So if they feel like maybe measles is the option for us now, but not cervical cancer, they would prefer to opt for that rather than having a cervical cancer support from Gavi. So that will in itself reduce or kind of put HPV vaccination on the back burner. But when maybe there is a structure where regionally this is what we want to do for the region, making sure that every country is able to get into that pool, then it's kind of different from the individual country's specific health needs. So in this case, you just go in like COVID and then get what you are entitled to and come to your country and then execute the program. So that is why I kind of subscribe to that approach.
Mm-hmm. Interesting. You should write an editorial on that.
Yeah.
Any other questions or comments?
Mary,
Go, Nell. Sorry, Nell, go ahead.
Eric, that was excellent. Thank you. I learned a lot. Thank you again. How did you measure political will? Just for my own learning purpose. In terms of methods, what did you use?
It's difficult to measure political will because that is a qualitative thing to do, and you can only measure that based on interest of actors. So, and that is also something that you cannot really tell. So you can only measure that trying to figure. You need to test and then know what they really want, what their gains are. So once you know the gains of actors, then you'll be able to figure out what their political wills are going to be. So, for instance, citing this, but Kagame's relationship with Meg, we can figure out the political will on the basis of Kagame's wife, or on the basis of Rwanda, and then also on the basis of Meg. What are their political will is the willingness to pursue a particular agenda, so the force or the interest and then the power you have together to push that agenda forward. So when you look at it, you have to consider Merck's interest in this whole project. Merck would be like, okay, well, we are going to give this 2 million doses. However, down the line, we might benefit. So there's that core interest there. So it kind of moves or trickles down to kind of policy analysis, trying to figure out what they want at the end of the game. You know, so sorry. So you run through that pot, and then you'll then be able to come to understanding of the political will of the actors.
So when you compare that to Canada, in order to stay consistent within the comparison, did you come up with indicators in terms of actual methods? Like, when you're comparing 3 case studies, you clearly show Canada had low political will versus the African countries. So I'm just, if I want to do it, if I want to replicate the study, what sort of indicators from a very methodological approach, what sort of indicators would I go for, or would you suggest me to select?
So in the case of, for instance, Canada, the reason why low political will was selected was because if we take Ontario, which was the case study, specific case study for to represent Canada, realize that the Ontario Standing Committee for Finance did not have any interest in the first place. Their interest only came in when the federal government said, that was 1 week after they said no, 1 week after the federal government came in and said, we are giving 300 million to support the program. Then they are like, okay, yes, we will now come on board. So that kind of signals that low political, we are on because we can easily access that money. Whereas in the other, in Rwanda, for instance, the force was really right there from the president's wife to the, the working committees and all of that. Before Rwanda went into the country 1 year after the relationship with Merck, the working committee was already ready, waiting for them. So it wasn't now that we're going to form the committee and then see how it works. So that tells you that they have a very high political will for the entire project to happen. So that the interest mainly drives the political will. Yeah. And then
like speed as well, right? Like how long did it take?
Yeah, so of course, when there's a political will, it's like the framework that was used to understand Rwanda's case is the multiple stream framework, which means that the policy actors actually would need to couple out the problems and then the policy action solution that will be provided, and then the political conditions in place. So that all of this wrap up and then create that window of opportunity. So time is also indeed a factor. So I think that all of these push down that funnel through that interest, and then also the power. Well, I would say some of these actors may not have too much power, but because they have enough interest, they're able to push through that funnel to get going. So when there is sufficient interest, it can also push or speed the process.
I have another question, but I'll come back later. Other question.
Okay. Well, I'm not seeing.
There's a question from Techno. What are the prospects of having? You see that?
In the chat?
Yeah, what are the prospects of having a vaccine for its prevention in Africa? What did this mean?
Yeah, you could try and address that one, Eric. Yeah.
What are the prospects of having a vaccine for its prevention in Africa? So I don't know whether it's the question is whether the production of vaccine in Africa or but to have the vaccine in Africa has the implication of having the vaccine in Africa is going to support in reducing cervical cancer or on the whole, and also it works within the framework of WHO's 2030 elimination of cervical cancer. So that is one of the main or core reasons why it is very important to have the vaccine on the African soil.
Right, and I think the other important thing to add to that is if someone has HIV/AIDS and then gets cervical cancer, their prognosis is much worse because HIV/AIDS reduces the capacity of their immune system. So they're not as able to fight cervical cancer, as someone who doesn't have HIV. And because, there's a higher prevalence of HIV in Sub-Saharan Africa than many high-income countries, it just gives you more reason to have the vaccine to prevent yourself from getting, cervical cancer in the first place. So, yeah, it just raises, I only found that out recently, but I think that's an important point. I don't know if you have any reflections on that.
Yeah, that's true. And then also I need to point out that whereas the HPV strains 16 and 18 are very prevalent or been known to cause about 70% of most cervical cancer cases. In Africa, it's been reported that other oncogenic strains are also contributing to this. So maybe in future, we need to have vaccines that actually have or kind of attacks these pathogens. And we do have, I think, 45 and then 50, 55 or so have been found to be causative agents for HPV, cancer, cervical cancer in Africa. So we need to expand that scope. So it looks like 16 and 18 prevalence is much more in the high income countries, whereas in low middle income countries, other strains are a major cause. So that's something that also needs to be looked at.
Right. So I guess there's a need for innovation in Africa that addresses those variants of the virus.
That's correct.
Yeah, sort of a locally, who's going to make it for them? Maybe they need to develop their own R&D capacity to do that.
Yeah, I think so. I think a lot of people have been speaking into that. The continent needs to have its own vaccine manufacturing facility to be able to deal with some of these situations. This has been after the advent of COVID, where they had to depend on high-income countries for the vaccine. So there is some kind of conversation that the continent needs to up its game on, being able to manufacture some of the vaccines that it requires. So I think that will also support R&D activities around these areas where it will be more focused on pathogens that they have to deal with.
Back to you.
Just out of curiosity, you said that in Rwanda there was still some pushback.
Yes.
On the vaccines because they said that on the basis that there are other priorities, it should trump the safety.
Yeah.
Just out of curiosity, I'm curious to understand what sort of tactics the government used to overcome the sort of pushback. And if that has some connection to the centralized form of government as opposed to not so centralized in Canada.
Okay, so actually the situation was addressed by the Minister for Health at the time and then her team. So the attack was that the vaccine at the time, we didn't know of its efficacy, whether it was efficacious over time. Okay. It was new on the market, and in spaces like the US and in Denmark, I think some few other countries, they were pushing back against it because they said enough data has not been collected to determine its efficacy. Even in Canada, people like Lipperman and some other individuals were speaking against. They were like, we need to really get enough information to be able to move forward. And also for a country like Rwanda, which was just coming from war, they don't have sufficient money, quickly trying to go into this, open up a lot of doors for questions to be asked. And also the minister at the time being on Gavi. And at the time too, people were saying that Gavi was much of a business than having people in the low middle income countries at heart. Mm-hmm. So all of this created opportunity for questions to be asked. She was on the board of Gavi. NEP was on the board of Gavi. So she had to actually address this systematically, that if we do have a vaccine that is free of charge, we are getting the 2 million of these vaccines free of charge. and then we have other competing priorities. Do we have to pay for, we are not, and Rwanda has, the cervical cancer is number one common cancer among women in Rwanda. So why don't we really proceed with this? Because at least there's an evidence that shows that it is safe and it is also efficacious. So we'll go for it. We will not wait for people to establish all the facts. So they decided to do that. And then when it comes to other competing priorities, it was also properly attacked. And it said, she stated that they have actually, they do have a track record of having a very high level of coverage. So they have programs in place. Everything is set. So there is no reason for them not to take advantage of the situation. And then Gavi has also promised to take over the project after the 3-year period when the 2 million vaccines will be provided there. So it was Rwanda being at the right place at the right time, taking advantage of everything and then moving on. So there wasn't any further point for the adversaries to attack again. It's like every single point was sealed, more or less. Yeah.
Well, just see if there are any other comments. I think, Eric, your paper recently on the Rwanda case study that you had up there actually goes into really nice details on, using the theoretical lens, the Kingdom's model of, you need to have the policy, the power, and the politics, our policy and the problem and the politics areas all aligned together, which really happened in Rwanda, as well as some of the other factors that, came into play as well. Anyways, it's a really nice case study. If any of you are interested in learning more, it really does go to the question of why Rwanda was so exceptional. But I think, Eric, we had talked about the challenges in Ghana, and maybe the issue is that the vaccine is not as effective because there are other strains of the virus that are also prominent in Africa. So maybe it's not as cost effective in Africa as it is in other high-income countries where those targeted vaccine strains are more prevalent. So
yeah, that's true. But if even say that is the case, and some, at least we have South Africa and Rwanda and a few others who have initiated this, and in the case of Rwanda, there is some kind of incremental decline in incident cases and then mortality. So it means that even though there might be other strains that are pushing, causing cervical cancer and all of that, the 16 and 18 that the vaccine attacks, when they do have it, is going to prevent that. So it's better for them to have it than not having anything at all. So I think in a way, having that ready to have it is better. That is my thought.
Probably 16 and 18 are probably still the majority, you would think, maybe just not as high a majority in other countries.
Yeah, so in Ghana, I think it's around, it's not up to 70, it's maybe between 68. There's a literature that I looked into some time back, it's around 68%, so which is still within the framework of the 70, not too far away. So having a vaccine will still be beneficial than not having at all. So in future, if the sub-region decide to have its own research team to develop a vaccine that will combat the other strains, that is also a welcome space to be.
Right. Do you think there could be any champion in Ghana, such as we saw in Rwanda?
Yes. So the former president's wife, Lodina Mahama, she was the one who spearheaded the 2012, 13, 14 arrangements. So she has
For the
been,
pilots in
Yeah,
with
she-
Gavi, yeah.
yes, so she kind of spearheaded that. She was a forefront, to it and all of that. So I believe, and Ghana also operates in such a way that once there is a public figure moving into that space, promoting it, everybody, falls on that bandwagon. So having a current or a sitting first lady being the spearhead of this means that it's going to go far. Breast cancer tends to receive high attention in Ghana because all the women group, the elite women tend to promote it and all of that. So it's able to gain a lot of traction, get governmental support, and then also donors are able to come in. It's not the same for cervical cancer. So once they are able to shift the discourse and then get the conversation around cervical cancer as they've been doing for breast cancer, I think there will be the need for them to get access through Gavi, or if even the Gavi have to come in, they will be able to do that.
Right.
Perhaps they could also, as the MEC does have the MEC outreach program, which help low-middle income countries get access to the vaccine. So this kind of situation could help them to tap into some of these resources and then be able to get the vaccine maybe a little bit cheaper, or maybe get some freebies, to be able to start the program with. So
Right.
a lot of opportunities to explore.
Right, because Ghana does have the infrastructure and they have a really good childhood immunization
Yeah.
program, right?
Yeah.
So in a sense, they have the infrastructure there, and so it's kind of a missed opportunity, but okay, well, great. Well, thank you so much, Eric. That was
Thank you.
really enlightening. And thanks to everyone for your questions and comments. And I would like to just mention that our next seminar next Wednesday is on invasive aquatic weeds biomass briquette production for cooking, implications on the health and livelihood, with Reginald Quansa. And again, that will be next Wednesday at 1 p.m. So please check our website for more information, and I look forward to seeing you next week. Thanks so much, everyone.